So this is my reporting and responding section. Called to a 20-year-old female with shortness of breath. On arrival, our patient had laboured shallow breathing and was only able to speak in short sentences. We checked her vitals and found that she was febrile tachycardic. However, her SpO2 levels were within normal limits. I auscultated her chest and found that her complete right side was diminished and her left side was partially diminished. I asked the patient if she had any allergies to medication. She said no, and then I administered 1 gram of paracetamol. However, the patient was unable to swallow this. She kind of choked it back up. She said she'd been struggling to eat or drink all day. I then went through my sample to get an idea of how the shortness of breath had come about. She said she had a cold for the past 2 weeks and had been to the doctor to get some antibiotics today. I asked her if she had a productive cough. She said yes, she'd been coughing up some yellow phlegm. And then on arrival to hospital, she came very hypertensive and needed fluids to boost her blood pressure back up. So the main issue identified within this case was definitely the treatment of sepsis in a pre-hospital environment. So relating. My mentors allowed me to be patient care officer for this job, so I was able to apply my systematic approach and also my respiratory assessment, including chest auscultation. And however, I didn't feel very confident in this skill as I haven't, done many chest auscultations on many people. But it was also a really good experience to, be a part of and do. I was quite excited to attend this job originally because I thought it was an asthma attack, which is something I've been very experienced with just from the jobs I've been having on placement and also the amount of university respiratory sort of scenarios we've been through. So I felt very confident about doing this job. I felt like I really had the knowledge and skills to handle this job with minimal help from my mentors, which was really awesome due to all the scenarios I'd been through at uni relating to respiratory. So the reasoning of this case, or the reasoning part. In this case, I believe it's important to have an understanding of the early signs of sepsis. As mentioned by the QAS CPM, diagnosis of sepsis requires you to have a believed site of infection and also evidence of systematic inflammatory response syndrome, characterized by being febrile, tachycardic, tachypnea, BGL of below 6.6, and an altered mental status. Did I say she was tachycardic? Yeah, she was also tachypnea. Sorry, I forgot to mention back further. This is validated by Cohen from the journal Medicine 2009, that states that clinical features of sepsis included all those characteristics I just mentioned before. In the case of my mentors, and I made a differential diagnosis, the site of infection was in her lung area due to a shortness of breath, and that the patient had these 3 symptoms that indicated she had sepsis. Indications by the QAS CPM state there are some key components of pre-hospital management of sepsis, including early identification, early oxygenation, early hemodynamic resuscitation, and also hospital notification. Further supported by Cohen, oxygenation is typically important, as most sepsis patients do tachypnea and suffer from hypoxemia. Our patient didn't, so that's why we didn't administer any oxygen. So this is the reconstructing section. The patient my crew and I attended, we believe only had sort of the beginning stages of sepsis. However, her symptoms were still detected and able to be treated on the way to hospital. I believe through this case, I've gained a better understanding of clinical features in the pre-hospital treatment of sepsis. If I were to come across this case again, I would really try and focus on getting a really good history, trying to work out where that site of infection was. And also, do a general vital signs survey. I believe having this solid foundation of evidence can help to not only quickly diagnose sort of sepsis, but also, you can provide accurate treatment. My ideas are validated by Scott E. et al. From the article Managing Sepsis in Adult Patients 2012. It supports that sepsis patients sepsis can be considered as a partial diagnosis if you can identify the site of infection and also if they show the correct clinical features. And due to this patient's pain, we were able to identify that it was in the lung region due to the fact that she was coughing up that phlegm and was really painful to breathe in and out for her. This is validated by Margot et al. 2013 from the Journal of Sepsis and Septic Shock, as it states that this is one of the most common regions for sepsis to occur. I believe after analysing this case, I now have a better understanding of sepsis and how to treat it in a pre-hospital environment. Thank you.